that Bill's interest in education in the medical community for the 40 or some odd years he had been here was very strong. So we settled on the project to provide a lecture series for physicians and other people in the community who were interested in the subject. When we went out to talk to people, it was really very heartwarming to hear the comments of people who were affected in their lives by this man. From the going up to the emergency room at 3 in the morning to help out with a sick kid, to counseling people in personal problems, to counseling people early on to go get a second opinion, which was anathema in the medical community in those days. But he had the sort of the guts to say, I think you ought to seek some other advice. So it snowballed from one person. We got the names of 3 other people, and they included the names that they gave us. It was really a very pleasurable thing. And what came out of it, we already knew it, but it kind of got focused. That Bill Dolan, the physician, the healer, the teacher, and the friend of many people in the community, is the fellow who we honored with this lecture series. I think that I know this is our 3rd of many. The endowment is, we raised $275,000. We're using the interest off that, and it's invested safely, Bill. It's not in any S&L. We're using the interest off that to have our annual series. So with that background, I say welcome, and I would like to introduce Jim Rita, who is the CEO and president of the foundation and president of the hospital. He came on board last year and has gotten in with both feet and is doing a fantastic job. Jim, I'd like to welcome you.
Games with this thing. Thank you, Ken. Well, it really is an honor for me also to welcome all of you to this 3rd annual William Dolan MD lecture. As Ken has so very well said, Bill is as close to the heart of this hospital and this foundation as one can really get. He has been here almost since the day the hospital opened its doors back in the 40s. His commitment to this institution and our patients and our medical staff has been a real driving force in the growth and success of this institution. Well, we're working very hard to ensure that we continue Bill Dolan's tradition of setting the highest standards of excellence at this hospital. We all want the best facilities, state-of-the-art equipment, and professional service possible, even in the face of some very difficult economic conditions that lie immediately ahead. That requires a real commitment from everyone involved in patient care. And I mean everyone, the housekeeping staff, our food service employees, technicians, nurses, administration, members of the board, and of course our medical staff. I am really extremely proud of the cooperation and teamwork that I have seen displayed here in the last few months, in the last year since I've been here. We've made many hard decisions and compromises in our budgeting process that would be the envy of, I'm afraid, everyone across the river in Congress. We will continue to strive for excellence in the spirit of cooperation as the year goes forward, because despite all the budgetary concerns, our real ultimate bottom line is quality patient care. Nothing is more critical to patient care than education of our physicians, and thanks to the generosity of those of you who created this endowment, we are able to honor Bill by bringing an outstanding speaker to further the education of our medical staff each year. So without further ado, further delay, let me ask the president of our medical staff, Dr. Robert Ryan, to come on up to the podium and introduce our lecturer for the evening. Bob? I'll do it.
Pleasure for me to represent the medical staff here tonight and to welcome all of you and to be part of an honor for Dr. Dolan for all the years of service that he has given us here in the hospital, particularly to the medical staff, as a physician, as a teacher. He certainly has led the way for us. Tonight we're very fortunate in having a very eminent authority in the field of cardiac pathology to give us an update, state-of-the-art type. He is a graduate of Emory University. He then has served many years the National Institutes of Health, the Heart and Lung Institute, as the chief pathologist. I won't recite all the litany of things that go with his name. You can read some of them in your programs. But amongst others, of course, he's clinical professor of pathology and clinical professor of medicine at Georgetown University. He's also the editor-in-chief of the American Journal of Cardiology. We're looking forward to hearing from Dr. Bill Roberts. Bill?
Well, thank you, Dr. Ryan, Dr. Haggerty, Mr. Reeder, Dr. Nolan, Mrs. Nolan. It's a great pleasure for me to be honored to speak in your lecture. I've known Dr. Dolan for many years. As already stated, his influence is far greater than just this one hospital. I feel like I've known him ever since I've been in the medical arena. I've never known anyone who's gotten two honorary doctor's degrees from the two universities closest to where he works. I think that says a great deal. Go ahead with the first slide. So thank you for this opportunity. What I'm going to talk about is coronary artery disease, atherosclerosis, cholesterol, something that affects all of us, I'm afraid. I think we need this lights off and those on. Now this is a coronary artery. For those of you who don't see coronary arteries every day, these are the arteries which perfuse our heart muscle. And the problem in the Western world from the health standpoint is that this is our major disease. This needs focusing. I need focusing. I gave a talk a while back, and I complained about every slide being out of focus. And this happened to be in South America, and I sat down, and a fellow said, well, that was a pretty good talk, but said, incidentally, every one of those slides was in focus, and what had happened, I'd forgotten to put my glasses on, so I was out of focus. But this is a coronary artery, and if you just look at that person next to you, one of you is going to die from atherosclerotic disease and have coronary arteries look like this. Next slide. Now, to get an idea how extensive this process is, let me show this. Now, these are the four arteries that I've mentioned that perfuse our heart muscle. And if we take these arteries and divide them into little bitty 5-millimeter segments, it turns out that we get about 55 little bitty 5-millimeter segments from each of our hearts. And what this column on the right shows, focus if you would, this shows what percent of these little bitty 5-millimeter segments are narrowed to this extent in cross-sectional area. And it turns out that about a third of the lengths of our coronary arteries are severely narrowed over 75%. If you take a circle divided into 4 quadrants, over 3 of them are obliterated in a third of the people. Now, sudden coronary death, what that means is sudden cardiac arrest outside the hospital. The typical person is sitting at home watching television set and suddenly is watching no longer. Another third of the lengths of these arteries is narrowed 51 to 75%, and only about 7% even approach normal. Now, this is the way it is in the people not only who die suddenly outside the hospital, but also those with acute myocardial infarctions in coronary care units across the country. It's also the same in people who heal their heart attacks and actually go on to die from something else. Now, this is an example to show you that diagram is actually accurate. This is the right coronary artery, and each one of these pictures represents a single look at a 5-millimeter segment. And try to go down this artery and find one that's normal or approaching normal. This is the left main, and this is the left anterior descending. Every portion of the artery has some plaque. Well, that one looks okay right here. This is the left circumflex, the dominant in this particular patient. Look at this way out here. Now, that's what the patient, and that's what the doctor, and that's what the nurse, and that's what the healthcare person is up against in coronary disease. If we look at this from the clinical aspect, clinically, of course, one talks in terms of one vessel disease, two vessel disease, three vessel disease, four vessel disease. Now this, with an angiogram, it looks like there's a narrowing at just one location. But if we could look at the lengths of those arteries in the patient with one vessel disease, it turns out that there's plaque everywhere. Just simply one artery is significantly narrowed. If we could look at the entire coronary bed of these four arteries in the patient with one vessel disease, now this is an average, it turns out that about 40% of the lumen is obliterated by atherosclerotic plaque alone. In the person with two vessel disease, now you've heard of people having two coronary bypass. Well, that means two vessel disease. It also means that all four arteries contain plaque, but there's particularly a lot in two arteries. Three vessel disease, the quantity of plaque's even more, and now 60% of the lumen is obliterated by plaque. The person is living on 40% of the lumen. And with four vessel disease, which means left main, 70% of the lumen approximately is obliterated. The person is living on 30% of the lumen. Now this is an aorta. I hate to show this before dinner time. If you have a slab of butter and leave it out for about 3 days, this is what it's going to look like. Now, this is the superhighway of our vascular system. I guess I've seen 500 aortas where every square millimeter was covered by an atherosclerotic plaque. The beauty of this, or the tragedy of this, it's unnecessary. We do not have to have atherosclerosis. This is not a degenerative disease. I'm afraid we are the degenerates. Well, I'm a cholesterol person. I think many of us have said through the years that this is a hereditary problem. You got bad genes. Well, folks, let me tell you, that's not the case. This is a genetic problem in 1 out of 500 people. The rest of us, it's determined, I'm afraid, by what we put in our mouths. So for the next few slides, what I'm going to try to do is show the case for cholesterol. This is not a controversial issue. The data is in. The connection between cholesterol and atherosclerotic plaques is overwhelming. It all started back in 1908, in Russia actually, when a Russian physiologist fed some rabbits raw red meat. Now it's very important that the animal chosen were rabbits. These are herbivorous animals. If the people back there had chosen a dog or a cat, it's not possible to produce atherosclerosis in them. But by giving this raw red meat, atherosclerotic plaques were produced. The physiologist attributed initially the plaques to the protein from the red meat. And then 5 years later, another Russian physiologist, Anishkow, gave pure fat to the rabbits, produced similar atherosclerotic plaques, and then he gave pure cholesterol and produced these similar atherosclerotic plaques. So it all really began in 1913. The next thing was that the biochemists came in biochemical analyses, found cholesterol, mainly esters, within these atherosclerotic plaques. And then not much happened until after World War II, item 3 there, and that's when the international epidemiologic studies came into existence. And this is what I conclude from those. I'll come back to that in a moment. Atherosclerotic plaques large enough to produce clinical problems occur only in persons having serum or plasma total cholesterol levels greater than 150. How many of you know your total cholesterol level? Wonderful. I hope you keep it in your wallet. And every time you have it checked, you record it. Now this 150 is an interesting number here. When we're born, our total cholesterol in umbilical blood is approximately 75. Within 2 weeks of life, it shoots up to 150, and then on the average, it stays about 150 until we graduate from high school, and then it gradually starts going up after that. I can tell you that pure vegetarians have a total cholesterol averaging about 140. If you really want to make sure that atherosclerosis will never be a problem in your life, keep your cholesterol in that vicinity, and it is indeed possible. Now, items 4, 5, and 6 really were confirmed the last decade. The higher the blood total cholesterol level, the greater the chance of having a symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Number 5 came in 1984. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. And number 6, the best study at least, came in 1987. Atherosclerotic plaques regress when high blood cholesterol levels are lowered. So in my view, any way one looks at this, the evidence is in the connection between cholesterol and atherosclerosis would hold up in any court in any land. Now this is the slide of the so-called 7-nation international study. This was done by Ansel Keys and his colleagues, started immediately after World War II. They went to these various countries, studied a total of a little over 13,000 people, found that people residing in certain lands like Greece and Japan had a very low incidence of coronary disease, whereas USA and Finland a very high incidence. Now, most of this data was collected in the 1950s, early 1960s. It may be changing a bit in Japan compared to that time. Now this is what Ansel Keys found. In southern Japan, the average total cholesterol was about 150. And look at the very small percent of the population that had total cholesterol levels greater than 200. Very small. In eastern Finland, on the other hand, these mainly lumberjacks, the total cholesterol was averaging about 280. This is a study which came out of Chicago, the Mr. Fitz study. Stamler was the main investigator here. This study is a very important one. It cannot be ignored. Why? Look how many individuals were studied. Over 350,000 individuals. These were all men, ladies, aged 35 to 57. When they entered the study, they were all asymptomatic. They were divided into 10 groups according to their serum total cholesterol level. And what this study so beautifully shows is as that total cholesterol level goes up, 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 and up, the coronary artery disease mortality, and this is a 6-year mortality, goes up, 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 and up. No study shows it better that the total cholesterol is a quantity. The higher that quantity, the greater the risk, and it's almost as simple as that. This study was important to the federal government because this was the study where the number 200 came into existence, and that is the goal, the objective of America, USA citizens, is for each of us to get our total cholesterol levels under 200. Now, if you look at 198, this study is what it was based on. These numbers below 200, and here the coronary artery disease mortality, the increase in mortality is relatively small from 150 up to 200. But after 200, it rapidly shoots up. And the average total cholesterol in serum in the USA now, in persons aged 20 to 70, is 215. So it's a very reasonable objective to say that we can get our total cholesterol levels under 200. Now, this is a study that came out of Oslo, Norway. The question asked by these investigators is, look, if we could look at the coronary arteries and determine how much atherosclerotic plaque was present in them. And if we knew the total cholesterol levels of these people, would there be more plaque in the arteries of those individuals with higher levels? And the answer is yes. As that level, total cholesterol level goes up, the amount of atherosclerotic plaque in the coronary arteries goes up, same as in the aorta. Now, this busy slide summarizes the two studies which have shown beyond a reasonable doubt that if groups of people lower their total and specifically the low-density lipoprotein cholesterol, that's the major atherogenic one, if those levels are lowered, that heart attack frequency drops. The one on the left here is the Lipid Research Clinic study. This study cost $158 million. It's never going to be repeated. The one on the right here is the Helsinki Heart Study from Finland. The two important items in these two studies, in my judgment, one is that they both show the same thing. And that is, if you put a group of people on a drug like cholestyramine or gemfibrozil to lower cholesterol levels, plus a low-fat, low-cholesterol diet, and then follow the people here 7 years, here 5 years, that those who were allocated to the drug therapy have a lower frequency of heart attack compared to those not on drug therapy after that period of time. So this was a 19% reduction, and this a 34% reduction in heart attack. The other thing about these studies is that they were analyzed in the most conservative manner possible. And what I mean by that is the people allocated to drug, they stayed in the drug arm of the study even if they quit taking the drug. And 30% of the people in this study, one on the left, and 30% of the study on the right, those individuals quit taking the drug after 1 year. Nevertheless, they remained in the drug arm of the study. And in this study, the dose of the remaining 70% dropped considerably. Nevertheless, they were analyzed as if they were in this study, as if they took the drug the entire time. If one compares those who took the drug and the amount allocated to those who didn't, there was a 25% reduction in cholesterol levels and a 50% reduction in heart attack. So it really pays to lower that level. Now, what those two studies show, analyzed very conservatively, is this. If we look at total cholesterol in the serum here, for every 10% it drops, there is at least a 20% drop in heart attack and more likely a 30% drop. So it pays to get it down. It also shows that if we raise our total cholesterol 10%, our heart attack chances increase 20%. Now, this is the title page of one of the three thus far published reversibility studies. This one came out of California by Blankenhorn and colleagues. What these investigators did was take a group of 162 people who had already had a bypass operation. And then they divided them into two groups. In one group, they treated with this lipid-lowering combination, cholesterol and niacin, and the other group did not receive drug therapy. Now, this was a study that compared those who took the drug to those who did not take the drug. And the average total cholesterol fell from 246 to 180. Now, these are the results. What this study shows, if you look at the drug compared to the placebo in red, number one, 0 means no progression. What they did here was do a coronary angiogram at 0 time, and then 2 years later repeated the angiogram. Now, if you take a group of people who have bypass operation within a 2-year period, one expects the narrowing to worsen. Now, what happened here in the drug group, 0 means the narrowing did not worsen, and that was higher in those who took the drug. More importantly is the minus numbers here. The minus means that at the initial angiogram, a severe narrowing 2 years later was less narrowed. In other words, the plaque actually shrunk. And shrinkage or regression was much higher in those who took the drug. Likewise, progression, the positive numbers, meaning that narrowings got more narrow, was much higher in those who did not take the drug. So even in patients who've had bypass operations, coronary angioplasty, to get that cholesterol level down pays big dividends. This is another study. It hasn't been published yet. It's going to be published, I believe, next month. This one used lovastatin and cholesterol, or niacin and cholesterol. And this was also an angiographic study, 2.5 years between the angiograms. And what it shows was that the progression was less in the group taking the drugs. Regression was much higher in the group taking the drugs. And cardiovascular events were much lower in the group taking the drugs. So it pays big dividends to go on a low cholesterol, low fat diet, plus take these lipid-lowering drugs after events. Now, how much of these atherosclerotic plaques are really reversible? What do they consist of? Now, this is a study done in my laboratory by a former colleague, Dr. Amy Kragel. And what was done here was we took these 3 subsets of patients: unstable angina, acute myocardial infarction, sudden coronary death. And we had all of these 5-millimeter sections of coronary artery to look at. And by a fancy telemetry setup, Dr. Kragel traced out the percent of the plaque consisting of these various components. Now, I think it surprises a lot of people that the dominant component of atherosclerotic plaques, at least in people with fatal coronary disease, is fibrous tissue. And these are what the plaques consisted of, those causing severe narrowing at that site. Dense fibrous tissue, loose fibrous tissue, cellular fibrous tissue, blue is calcium, and the green is pultaceous debris. Now what that means is this is lipid material, this is cholesterol, this is extracellular. Now there's no question experimentally that all of this lipid material is reversible. And that makes up a relatively small amount of the plaque. There is some evidence experimentally that the cellular fibrous tissue is also reversible. But the amount that's reversible is relatively small. But loss of small quantities from a functional standpoint makes a great deal of difference. Now this slide to me is even more important than the last one. The question asked on this slide is, what is the composition of these plaques according to the amount of cross-sectional area luminal narrowing? In other words, are little 5-millimeter segments that are minimally narrowed, do they consist of the same thing as the plaques which cause severe narrowing? And the answer is no. But it's interesting that in the plaques that cause little narrowing, the dominant component is cellular fibrous tissue. Now, as the artery gets more narrowed, the amount of cellular fibrous tissue decreases and the amount of dense fibrous tissue increases. Lipid, on the other hand, which is the green here, lipid increases as our plaques get bigger. Lipid is not the first thing in the plaque. I think it's the last thing. The connection between lipids and thrombus is another story that I won't go into, but that's going to be a very important portion of this in the next 3 or 4 years. Now I would like to switch gears to nutrition. I don't claim to be a nutrition expert, but I think we all need to learn as much about it as we can. When I was in medical school, I don't recall hearing a single lecture on nutrition in 4 years. I didn't hear the phrase saturated fat discussed, as I recall, in my entire 4 years in medical school. So all of this is relatively new to me. Now this is a slide which summarizes investigations of 3 groups. Each line represents a different group. And what this shows is that as we increase our intake of cholesterol, our cholesterol level, the total in our blood, goes up. All 3 groups showed the same thing. So one easy way to increase our cholesterol level is simply to eat the stuff. Now, we've all heard, well, you know, we're diminishing the amount of beef we're eating. I just eat chicken or turkey or fish. Well, and the idea, I'm afraid, has been, well, therefore, we will take in less cholesterol. But unfortunately, that's not the truth. And what this slide shows is the amount of cholesterol in milligrams in 100-gram portions of food. Now, how much is 100 grams? Well, I can tell you that a deck of cards is 100 grams. So what you need to do is picture in a plate a deck of cards. And a deck of cards of pork, veal, beef, chicken, turkey, lamb, and most fish, the amount of cholesterol is the same. So if you switch from beef to chicken, don't do it because you're going to get less cholesterol. And fish are very interesting because you can pick what you want in fish. If you have perch or smelt up here, you're going to get more cholesterol than in a steak. On the other hand, salmon, tuna, halibut are at the low end. But I don't worry about cholesterol. Most of us in the USA take in about a half a gram of cholesterol. Now, what's a half a gram? I can tell you that's 5 toothpicks. And that's all we take in of cholesterol. And there's not even any calories in this cholesterol. The thing about cholesterol is that it comes entirely from animals and their products. So if we didn't eat animals and their products, we would eat no cholesterol. Eggs, visible and non-visible, if we'd give up the eggs, we'd reduce our cholesterol intake in half. If we'd give up the red meat, that would take care of most of the rest. On the other hand, this three-letter word fat is the real villain. Most of us in the USA take in about just over 140 grams of fat per day. In other words, we take in 200 to 300 times as much fat as we take in cholesterol. And about a third of that fat is saturated, and that's the villain. Let's say we take in 120 grams of fat. That means about 40 of that is saturated. And what happens with that saturated fat, when it enters our bodies, it's converted to cholesterol. So our biggest source of cholesterol is not the direct stuff that we eat, but that coming in from the saturated fat. Now, not all of these fatty acids are bad. They all are high in calories, but it's the saturated one, the black ones here, that are bad for us. The monounsaturated, the polyunsaturated either lower our total cholesterol, or at least they have a neutral effect on it. Coconut oil, that's about the worst thing we can put in our mouths. That's 92% saturated fat. Palm kernel oil, 86%. Butterfat, 66%. Beef tallow, 52%. The ones on the left are good. There's some evidence from Scott Grundy's group that monounsaturated might be better for us than polyunsaturated. Good olive oil is 77% monounsaturated. Peanut butter, 48%. Those are the ones that we need to eat. Now, my wife is here, and she knows I don't go to the grocery store hardly if I help it, which is virtually never. But it's my understanding that the word saturated does not appear in any grocery store in this nation. The word is hydrogenated. And what that means, that's a synonym for saturated. Now, these chemical formulas of the fatty acids are very different from the chemical formula of cholesterol. And a monounsaturated fatty acid has one double bond. And so the carbon atoms at that side are not covered by hydrogen atoms. So if you hydrogenate that monounsaturated, you break that double bond and add hydrogen atoms. So it becomes hydrogenated. So if you see that word hydrogenated, beware, don't buy it. Just leave it on the shelf. Now, Michael Jacobson and Sarah Fritzner are from this city, and they wrote this book 3 years ago called The Fast Food Guide. It's a wonderful book. What they tried to determine were the ingredients of the foods served by the 15 top fast food chains. As you know, this is over a $60 billion industry in the USA. 1 out of every $2 spent for food eaten outside the home in the USA is spent in a fast food chain. 20% of Americans eat their lunch every day in a fast food chain, 13% their supper, 5% that begin their day at breakfast in one of these things. Now, these folks went to the top 15. They would order something and then ask the waiter or waitress what the ingredients of the particular food or drink they ordered was, and most said they didn't know. Some would go back to the kitchen and bring those big barrels that the foods came in, and sometimes the ingredients would be listed on the outside. And some of the waiters and waitresses would ask them, what does that word ingredients mean? So that's about where we are, I'm afraid, in some of this fast food business. Now, if we look at the Wendy's triple cheeseburger, I can tell you folks that this is the coronary artery bypass special. And it is closely followed by the Burger King double beef Whopper with cheese. Now, we are talking about 1,000 calories in that one hamburger. And if you take that sucker and squeeze it real hard, you can come up with 15 teaspoons, that's teaspoons, not grams, teaspoons of fat, much of which is saturated in that single hamburger. Now, this word here is sodium. It's not salt. It's not sodium chloride. It is sodium alone, and here we have 1,800 milligrams, 1,200, 1,300, 1,800. Now, of course, we have to have some French fries with our hamburger. A baked potato is one of the better things we can eat, you know. It averages about 100 calories. It's 1% fat, 13% protein. But if you chop it up and cook it in beef tallow, which most of these places do, which is over 50% fat, good old Taco Bell, until last year, cooked theirs in none other than coconut oil, 92% saturated fat. Hardee's has changed. Hardee's is one of the lower ends now. They cook them in a good vegetable oil. At the time that this slide was made, they could quadruple a caloric count of a baked potato. Another 5 teaspoons of fat and over 300 milligrams of sodium. Now, it's hard to drink water with a meal in this country. One of the things about weight is that so many of us drink concentrated calories in the liquids we drink. This is a new occurrence relatively in the world. The queen of the liquids is the Dairy Queen chocolate shake large, 20 fluid ounces. We got another 1,000 calories in that one milkshake. Another 6 teaspoons of fat and over 350 milligrams of sodium. Now, this fellow John Love wrote an interesting book. He called it McDonald's Behind the Arches. Some of you may have heard Bill Castelli, who heads the Framingham group, talk about this subject. Castelli calls the arches of McDonald's the entrances into the pearly gates. And, look at this about McDonald's. In 1985, 96% of Americans ate at one of McDonald's restaurants. Slightly more than 50% of the population of the USA lives within 3 minutes of a McDonald's. This is an old slide. McDonald's has served over 70 billion hamburgers. McDonald's is the biggest purchaser or killer, whatever your perspective is, of cows in the world. Since they started Chicken McNuggets, they're the biggest purchaser, second biggest purchaser or killer of chickens in the world. They're the biggest purchaser of the potato crop in the world. Look at number 7. McDonald's has employed at one time or another 8 million workers. 7% of the entire U.S. workforce, and McDonald's has replaced the U.S. Army as America's largest job training organization. McDonald's is the world's largest owner of commercial real estate, and this is the best of the outfits. I think they're going to lead in the change. This fellow Tom Parker wrote an interesting book entitled In One Day. The question he asked is, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food are consumed every day, roughly 200 billion more than we need. Those 200 billion left over would feed the whole country of Mexico every day, no problem. In 1989, we adults in the USA reached 60%, meaning 3 out of every 5 Americans aged 20 and over are overweight, 60%, and 30%, frankly, obese. Nearly 100,000 cattle are slaughtered every day in the USA, yielding 60 million pounds of red meat. About 250,000 hogs are butchered every day, and 4 million pounds of bacon are eaten every day. Bacon is really the pits. Bacon is 80 to 85% fat. If you have a plate with 2 eggs on it and 3 strips of bacon, leave the bacon and eat the eggs. If you don't know what it is, make a hot dog out of it, and we eat about 47 million of them every day. McDonald's puts 2,500 cattle on their tables every day. Dairy cows yield 47 million gallons of milk. We eat 170 million eggs every day, and maybe as many as 12 million chickens every day. We eat 50 million pounds of sugar every day, an average of 21 teaspoons apiece. Can you imagine waking up in the morning and eating 21 teaspoons of sugar? And that's what we eat on an average every day. These processed foods that we all eat are loaded with sugar, and they're loaded with salt. We also eat 3 million gallons of ice cream every day, and there's more sugar in the ketchup for our hamburgers and hot dogs than there is in ice cream. McDonald's boasts, for example, that they have served an amount of ketchup equal to the entire river basin of the Mississippi River. So we are swimming in ketchup in this country, folks. We also eat about 10 million pounds of candy every day. We drink 16 million gallons of beer and ale, and 1.5 million gallons of hard liquor every day, enough to make 26 million Americans thoroughly drunk every day. We still smoke 85 million packs of cigarettes. We still have 47 million cigarette smokers. I'm pleased to say that physicians are down to 9%. I heard recently that medical students, at least in the USA, are down to 2%. I like this statement by William Collins. The carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these two foods. It is virtually impossible to produce atherosclerosis in the dog even when 100 grams, now 100 grams is 200 times the usual amount of cholesterol taken in by an adult in America every day, plus 120 grams, a quarter pound, of butterfat every day in the meat ration. Adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months, on the other hand, produces striking fatty changes in the arterial wall. Now, you tell me, are we a rabbit or are we not? A person who eats meat is personally responsible for the slaughter of 22 warm-blooded animals per year, 1,500 in a lifetime. Now, you tell me whether we are carnivore or whether we are herbivore. Now let's look at our appendages. Do we have claws or do we have hands? Now our teeth, well, you can argue that the teeth in the front of our mouths are pretty sharp, therefore we are omnivores. But I would say that most of our teeth are flat. They're for grinding those fruits and vegetables. Now our intestinal tract, is it short like a carnivore or is it long? Of course it's long. The small intestine itself is 26 feet in length. It's that long, apparently, so that we have plenty of time to absorb all those nutrients from the fruits and vegetables that we're supposed to be eating. On the other hand, a dog has a very short intestinal tract. You give a dog something to eat, they've got to go outside in a few minutes to do their thing. Now, when we cool our body, do we pant or do we sweat? When we drink water, do we lap it or do we sip it? Now carnivore make vitamin C themselves, whereas, of course, we obtain it entirely from our diet. Now, we think we're one of these, and we act as if we're one of these, but, folks, we're not one of those. Now, let's divide us people here into 3 groups. And on that side over there, put the pure vegetarians over many, many, many years. And on this side, put the meat eaters, which most of us are, and right down the center, put the ovo-lacto-vegetarians. And ask the simple question, what diseases do those pure vegetarians over there not get that these meat eaters over here get? Well, the pure vegetarians, they're not bothered by atherosclerosis. A pretty major problem in this country is going to kill nearly half of us, but the pure vegetarians don't get it. Systemic hypertension, we have at least 60 million Americans with systemic hypertension. But those pure vegetarians over there, they have normal blood pressure. Cancer, 2 of the 3 most common cancers are extremely rare in pure vegetarians. That is, cancer of the colon, cancer of the breast, cancer of the prostate gland apparently is also very uncommon in the pure vegetarians. The pure vegetarians are not bothered by adult onset diabetes. They don't get, they're not obese. They don't get peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, hiatal hernia, irritable bowel syndrome. If we were all pure vegetarians, a gastroenterologist, a general surgeon would be out of business. The pure vegetarians don't get gallstones or kidney stones. They're not bothered by osteoarthritis or osteoporosis. As you know, in this country, osteoporosis is a major problem, and it's more of a problem for reasons I don't understand in women than in men. Now, the milk industry, the fat industry, the beef industry tell us that it's because we're not taking in enough calcium. And if we would drink more milk and eat more food, meat and so on, we would get more calcium. Well, that's almost certainly not the case. It's almost surely a protein excess. We all take in too much protein in this country. The more protein we take in, the more calcium we lose. Osteoporosis is not a problem. It's just unheard of in pure vegetarian societies. And of course, salmonellosis and trichinosis are not problems of pure vegetarians. So could we improve the health of us, this nation? Could we decrease the health costs? I think we can. If we would simply eat these type foods, many of our health problems would vanish. I sort of like these animals. Winston Churchill used to say that the elephant, other than human beings, was the smartest, and the second smartest was the pig. We don't treat them that way, though. Now, let me switch gears here a moment. Suppose we switched from a meat-eating society to a non-meat-eating society. What benefits would incur to our country and to us? Well, back to people for a moment. The starvation would cease around the world. We have about 5 billion people on the planet. It's estimated that at least 60 million starve to death every year. But that would vanish. One of the problems, or the major problem, at least in the Western world, and this was pointed out by Mary Moore LePay, whom I consider really a great woman, that most of the crops grown in the ground in the Western world, and certainly in the United States, go to the livestock. They do not go to people. For example, the oat crop, 95% of it goes to livestock, 5% to human beings. Corn crop, 80% to livestock. Now, why do we do that? Well, one of the reasons, of course, is that we take these cows in this country, and we have 100 million of them, and we kill 35 million of them every year. During their last 2 to 6 months of life, we pin them up in these feedlots, and there we feed them an average of 22 pounds of grain and soybean every day. And why do we do that? Well, we do that, of course, to make them fat, and that makes them taste better. And then we kill them, and then they kill us. And it's as simple as that. Now, the animal killing depends on who you read, but we kill anywhere from 9 to 12 million animals in this country every day, and that does not include the estimated 1 million run over by motorized vehicles. So it is a problem in this country. Soil erosion. We're wearing out the land, folks. We're wearing it out because we growing the crops to feed the cattle and the livestock. It's estimated that, and this comes from Robbins, that the topsoil in this country 80 years ago was 21 inches high. It's now down to 6 inches. It's estimated in 40 years it will be a zero. We will be importing food in 40 years. And where are we going to get it from? Destruction of rainforests is a disaster. We don't naturally have this oxygen to breathe. And, you know, we all know what's happening to Amazonia. In Central America, that's where most of the hamburgers come from in the fast food industry in this country. In Central America alone, the rainforest has dropped from 130,000 square miles to 70,000 square miles since 1960. Species extinction, we're losing them as we lose every acre of rainforest. The water supply, industry is not responsible for the major one responsible for polluted water supply. The major pollutant, apparently, the excreta of the cattle. When they're put in those feedlots the last 2 to 6 months of life, how do we get rid of that excreta? It's a major, major problem. The excreta of a cow is 16 times that of a human being every year, and it ends up in our water supply. Energy crisis, I bet if we were not a meat-eating society, we would not need to be in Saudi Arabia today. And of course, we'd all be richer, we'd all feel better. Just ask a pure vegetarian. Now this slide comes from the Harvard School of Public Health. It has to do with body weight, shown here in the horizontal axis, and what they call mortality ratio, which is a fancy way of saying when we die. But what this slide shows, whether you're man or whether you're woman, the more we weigh, the sooner we die. Now that's in groups of people. We can always point out the Winston Churchill's exceptions, but the more we weigh, the sooner we die. Now this slide came from an article on cancer of the breast. Why are you talking about cancer of the breast? I thought this was a heart talk. This was published last year in the JAMA. It shows on the horizontal axis here the fat consumption of adults in these various countries, and on the vertical axis the cancer of the breast death rate. And here, the USA, we're right there, over 140 grams of fat per day. And we have one of the highest frequencies of carcinoma of the breast in the world. Now, what this slide so beautifully shows is that the more fat any society takes in per day, the greater the chance of carcinoma of the breast. Now, this could just as easily be carcinoma of the colon, two of the three most common cancers. And yes, it could also be systemic hypertension. And yes, it could also be atherosclerosis. The point is that we could diminish greatly our two most common heart diseases, namely atherosclerosis and hypertension, and two of the three most common cancers, namely breast and colon, if we would take our fat intake and push it way, way to the left. So can we improve our health? Can we decrease our costs? Yes, I think we can. This came from a study during World War II, 1939 to 1945, and as you know, in certain countries in World War II, there was not much meat available, and there was not much cheese and butter and milk. And what happened to the cardiovascular death rate? Well, in the Scandinavian countries, look at Sweden. Boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. In the USA, it just kept on going. Now, this is the recommendation of the American Heart Association, their Phase 1 diet. And I think they're very nice to us. In the USA, we take in an average of 40 to 42% of our calories from fat. Incidentally, that's what you want to know about a food, is the percent of calories from these three things. Now, that's very difficult to find in a grocery store. You have to calculate it from the grams. The American Heart Association recommends we decrease our percent of calories from fat 40 down to 30%. Well, if we do that, it'll lower our total cholesterol about 8%. Modest, it would be useful, and if the whole society did that, it would make a very dramatic change. Now, the Japanese, on the other hand, 10% of their calories already are from fat. So we eat 75% more of our calories from fat than do the Japanese. And we, I believe, should make an attempt to decrease our percent of calories at least down to 20%. It won't be easy, but our health will skyrocket. Now, these are the presently available lipid-lowering drugs. I think these are splendid drugs myself. They are relatively non-toxic. About 1% of the people on the bottom 4 here get some liver function abnormalities, but as soon as they're taken off the drug, they go away. But look at the effects on the total cholesterol, the low-density lipoprotein cholesterol, the HDL. This is the good cholesterol. Some of these drugs increase that quite a bit. So we're in a new era now. I think the number of drugs to lower cholesterols are going to increase enormously in the next few years. Now, some people say these drugs cost too much. My patients can't afford them. Well, your patients seem to be able to afford a bypass operation. Last year in this country, we had over 250,000 bypass operations. It cost over $8 billion. Last year we had approximately 300,000 coronary angioplasties, and that cost over $4 billion. If we gave every person with symptomatic myocardial ischemia one of these lipid-lowering drugs, it would cost less than $3 billion. If we would diminish the size of the meat on our plate and put that money into a lipid-lowering drug, they wouldn't cost us much at all. Now, the recommendations when to use these lipid-lowering drugs, in my view, are too high. Most recommendations today don't use them unless the total cholesterol is over 240. The problem is that most people who have heart attacks have total cholesterols between 200 and 240. And that's the group, I think, that needs the most work. I was at a party with my wife several years ago, and there happened to be a senator there. Don't go to many of those parties, not invited. But the hostess, anyway, told the senator that this was a doctor over here. And I talked to the senator, and he said, look, I'm so happy. I went to my doctor today, and my total cholesterol is only 225. And I said something nice, but what I really wanted to tell him was that, Senator, do you know what the average total cholesterol level is of people in coronary care units around this country with heart attacks? And the answer is 225. That's the most dangerous level in America. And that's the one we got to do something about. Actually, I favor giving these lipid-lowering drugs to people who've had coronary angioplasty. This is how angioplasty works. You stick a balloon, right, the catheter with a balloon on it, and it breaks this plaque up, and then you get more lumen. But the plaque is still there, and we need to still do something about that plaque. I think it's a wonderful procedure. I'm not against the procedure. The bypass operation, I think it's a wonderful operation. This is a saphenous vein here. Now, that belongs in the leg, of course, but in the last 4 years in that patient's life, it was in the aorta coronary position, used as a bypass. And here 4 years later, it's filled up again with atherosclerotic plaques. Bypass is not enough. Angioplasty is not enough. We need to get those cholesterol levels down further. I believe in anybody with symptomatic myocardial ischemia being put on a lipid-lowering agent right away, as well as a low cholesterol, a low-fat diet. Let me end this by some observations by these 3 anthropologists. Melvin Connor here is a world-renowned anthropologist. His wife, Marjorie Shostak, also is in that category. Now, Melvin Connor and his wife went to Africa and spent nearly 3 years there studying the bush people. And they think the bush people live like our Stone Age ancestors did over 35,000 years ago. And I think some of their observations are interesting. Many diseases in the late 20th century USA were uncommon, rare, or non-existent among our Stone Age ancestors. Our genes have not changed since anatomically modern humans became widespread about 35,000 years ago. Or from a genetic standpoint, current humans are still late Paleolithic, pre-agricultural hunter-gatherers. Therefore, we've got a major mismatch on our hands. In contrast to our genes, our culture has changed enormously, beginning with the agricultural revolution about 5,000 years ago and accelerating since the Industrial Revolution. In other words, we have Stone Age bodies in anatomic age. Our remote ancestors had little or no exposure to either tobacco or alcohol. Their lives required both aerobic and resistance exercise, and their nutrition was derived almost exclusively from wild game, not fat domesticated cattle, but from wild game. Very little fat in there, more polyunsaturated fatty acids in there, and uncultivated vegetable food. Obesity, diabetes, hypertension, atherosclerosis, and the most frequent cancers are diseases resulting from our current genetic lifestyle mismatch. The present societies who do not develop atherosclerosis, there's still a few on the planet, live like our Paleolithic ancestors. They have low blood cholesterol levels, no hypertension, do plenty of physical exertion, do not use tobacco, and their diets are low in total fat and have more polyunsaturated than saturated fatty acids. Their blood's even thinner than ours. I think many of us say that atherosclerosis is a consequence of aging. The older you are, the more plaques we have. Well, I say we don't have to develop atherosclerotic plaques just because we get older. These are coronary arteries in a woman who is 103 years of age. That's her left main coronary. I'll trade with her right now. It's beautiful. This is the right. That's the biggest plaque in her body right there. This is left anterior descending. Beautiful. 103 years old, poor woman, was run over by an automobile. I think Mark Twain had something to say. The only way to keep healthy is to eat what you don't want, drink what you don't like, and do what you'd rather not. So, folks, lights on. Thank you very much.
Everybody wants to get in and get at those hamburgers. Questions? Yes.
No, that's a myth. More iron in spinach than anything. The amount of iron in meat is relatively small compared to the quantity. Now, I don't think I'm pushing vegetarianism here as ideal. I realize that's unrealistic in our society, but I think we must diminish the quantity of food, of meat. I mean, most of us fill 3/4 of the plate with meat. You know, the child leaves home in the morning, Mommy, what are we going to have for dinner tonight? Well, she has to say meat. It's steak or chicken or turkey. That's the first focus. I guess if she said okra or something, the kid wouldn't come home. But
Yes. Other question?
Yeah. Well, the problem is that the average age of death from coronary disease in men is 60. 60. The average age of death from coronary disease in women is 68. Now, this is without some of the newer procedures like bypass operation, angioplasty, and so on. But it's not an old person's disease. It's a younger person's disease. The only societies, in truth, that are vegetarian societies are the undeveloped ones. We don't have enough people yet in this country to study it. It is a problem, you know, if all of a sudden we gave up meat, what would we die from in this country? Would all of us live to be 90? And if that was the case, what would we do then? I mean, we couldn't afford it as a country. But people have symptoms of myocardial ischemia as a rule a good bit of time before the end. Yes, sir.
Is it not true that many of these kinds of findings outside, although the mortality is really some now, total mortality is not related
That's correct. Both the Lipid Research Clinic study and the Helsinki Heart study have shown no difference in total mortality. That is, the actual number of people who died in the drug arm of the study versus the placebo arm of the study. On the other hand, the deaths from cardiovascular disease did drop quite significantly. The Lipid Research Clinic study, I think it's important to keep in mind that these people were taking 56,000 milligrams, 56 grams of this Questran every day. I think if I had to take that every day and rode a bicycle or a motorbike, I might be a little more tempted to have an accident. There were some freaky accidents in that study, but it is true. It is. You did state the fact as it is.
Anybody else want to challenge the statistics? Jim?
Do you advocate cholesterol screening in children, number one? And number two, we have a active cholesterol screening program here at Cardiology. Frequently we'll have people come in maybe twice a month who have not changed their diet at all, but will see a 40 milligram percentage difference in cholesterol. I realize there is individual biological variability. How much do you allow like that?
Yeah. Well, the first question, doing cholesterol screening in children, I think that's still being discussed. I don't think correct me, Dr. Griffith, if I'm wrong, but I don't think the American Heart Association or the pediatric societies have made a firm recommendation on that. Isn't that correct? I don't think there's a justification for doing screening in children unless one or both parents clearly have very elevated cholesterol levels. I think in most of us, starting after age 20 is very useful. Now, the variability in cholesterol levels, I think it's very important that the blood be drawn the same way each time. For example, if one goes into a physician's office and sits down and somebody puts a tourniquet on and draws the blood very quickly with the tourniquet on, and then the next time they go into that person's office, they sit quietly on that chair for 5 minutes before the blood's drawn, and then after the needle is put in, the tourniquet is taken away. The blood drawn, in other words, differently than the first time. One can have a 10% error in total cholesterol levels there. Now, the way to get around that, in my view, is just to do a lot of them. It's actually relatively cheap, and if one does a lot of them, they stay more or less in the same range. I keep mine in my wallet, and whenever I see a free place, I get it done.
Are plaques reversed one form?
Well, there's no question that the lipid portion is entirely reversible. That's been well shown in monkeys, rabbits, and so on. There is some evidence that the cellular fibrous tissue portion is reversible, and that's a major portion of plaque. The problem is one does not have to take away a lot of the plaque before the functional benefit is enormous. One of the things that's interesting about vascular disease is that we can fill up 3/4 of the lumen of our arteries before any problems occur. So we have 75% to work with. I mean, we can be very evil for a long time and still be home free. So I think just little shifts can make a lot of functional difference.
Yes, sir.
Well, that's a little heavy for me. I mean, I think genes are extremely important, but from an atherosclerotic standpoint, I think genes. We're all it's a polygenetic thing. In other words, any of us can. One person can eat 3 eggs, and it does not change the total cholesterol level of that person. Another person can eat 3 eggs, and it'll shoot it way up. So we all have a individual variability, and some people can eat the identical diet, and their total cholesterol will be 200. To another person, it'll be 180, and another one 220. But nevertheless, all of us could benefit by diminishing that 3-letter word fat. That is determining our fate. Yes, ma'am. Yeah. Well, that's actually relatively tough. I know a person who has a total cholesterol of 300, and the HDL is 125. Now, that's a pretty good ratio, and so the ratio between the total and the HDL is excellent. But I don't believe in that ratio very much, to be frank with you. I think the LDL in that person is still too high, and I would try to get the LDL down. Now, the other extreme is the person who has a total cholesterol of 170 and an HDL of 5 or 6. Now, that person's in serious trouble, and that person needs to get that HDL up. And unfortunately, none of the drugs in people who need the HDL really up are very effective.
I'm afraid we're going to have to cut off the questions so we can get next door and get into the food. As expected, Bill, it's excellent. Particularly so they won't get the idea that you're an entertainer. You are really an egghead who is able to get down to our level and give an explanation, again, without notes. You certainly have held up the high standard of talk that we've had, thanks to John Dolan and Bob Ryan, with 2 previous speakers, and this is certainly of the same caliber. We appreciate your coming. Thank you very much.
To close this session, I would echo the thanks and the praise. Thank you very much, Bill. Everyone's invited to come next door, and if your conscience will allow you to have something to eat. And please, everybody be back here next year. Everybody, all right? Everybody. You've heard the word. Thank you.